Değerli meslektaşlarım, toplantımızın bu oturumunda bir değerli başka konuğumuzu ağırlayacağız. Sabah açılışta da Yeşim Erbil Hoca'nın ifade ettiği gibi Profesör Henning Dralle daha önce de bizim toplantılarımıza katılmıştı. Bilgi birikimini bizlerle paylaşmıştı. Bugün kendisi tekrar bizim aramızda. Kendilerine huzurunuzda bir kez daha bize katılımlarından dolayı teşekkür ediyorum. Kısa bir özgeçmişini sunmayı uygun buluyorum. 1976 Heidelberg Üniversitesi mezunu. Şu anda yansıda da görüldüğü gibi University of Halle'de Cerrahi bölümünde çalışıyor. Kendisi 2008-2010 yılları arasında Avrupa Cerrahlar Birliği'nin başkanı ve 2005-2007 yılları arasında da International Association of Endokrin Surgeons'ın başkanlığını üstlendi. Şu anda bilimsel kariyerine baktığımız zaman 386 tane yayınının olduğunu ve 3971 site edildiğini bu yayınların görüyoruz. Değerli meslektaşlarım, hepimizin de bildiği gibi Almanya Avrupa Birliği'nin nüfus açısından en büyük ülkesi, 82 milyon ve bunun içerisinde 15 milyon Guatrda hastası var ve her yıl Almanya'da yaklaşık 100.000 tiroidektomi ameliyatı yapılıyor. Dolayısıyla böyle önemli bir ülkeden önemli bir konuğumuzun bilgi birikimlerini bizlerle paylaşacağı için ben şahsen mutluyum. Bunu da sizlerle paylaşmak istiyorum. Profesör Henning Dralle, please.
Thank you very much for these excuse me, for these very kind words of introduction. It is a great pleasure for me to be here and to accompany the meeting and the discussions. I followed the group and the meetings who have taken place in the years before from its beginning, and of course also this is a great pleasure for me to see the progress, the real progress in these meetings, the attendance rates, and also the very lively discussions. I think you have a perfect program for this meeting here, and my task is to talk about surgery for endemic goiter. It is a very difficult issue. On the one side, perhaps it is very easy because worldwide standard procedure for these patients is, during the last years, total thyroidectomy. On the other side, and this is the reason to stay here and to talk about that, at least in Germany, there was a very intensive and controversial debate about the extent of surgery and the option for individualization of this treatment, because the endocrinologist said the complication rate is much higher from the point of view of the endocrinologist because they are performing the follow-up investigations in the patients than reported by the surgeons. And the other part of the debate was that during the last years, the number of medical legal malpractice claims is increasing, and especially due to complications after total thyroidectomy. I will show the data during my talk, and perhaps half of them are related to recurrent laryngeal nerve palsy, and a quarter of them related to hypoparathyroidism. So the question is, what is the reality of total thyroidectomy due to multinodular goiter? And we talked about that issue before in the session before. What is experience? what are the results in the so-called community hospitals. So this is the reason I would like to talk about that issue, and it is perhaps more an insight in that debate than a player for subtotal thyroidectomy, of course, because we also are performing total thyroidectomy as the standard procedure for multinodular goiter. But perhaps there are some indications to decide in the individual case to prefer subtotal or less than total thyroidectomy as well. So the surgical aspects of the background are arguing for a subtotal thyroidectomy in special cases, that the pathology and the pathophysiology of endemic goiter is still today not fully understood, and if you have a pathophysiology that you do not fully understand, of course you cannot perform a causal procedure and a causal treatment. Endemic goiter is not a uniform disease. It comprises a spectrum of different entities, and that means in many cases, or if not all cases, you have an unpredictable natural course. So there are alternative treatment options like iodine or thyroid hormones, radioiodine therapy, and surgery. So surgery is only one of these options. Although thyroid malignancy may be masked by endemic goiter, in most cases, and this has been shown, I think, very clearly before, thyroid cancer, at least the clinical forms of thyroid cancer, can be detected by ultrasound and fine needle aspiration cytology in most cases, obviating diagnostic thyroidectomy. So we are coming to the more complication-related arguments. And endemic goiter affects not only the old patients, but also the middle-aged and the young patients. And for each of them, harm of surgery may be more burden than the disease itself. So it depends on the extent of disease, of course, and the potential risk of complication on the other side. So in countries with endemic goiter, surgery cannot be specialized to some dedicated centers only, and this is what the colleague said in the introduction. In that regard, Germany still is a endemic goiter country with 100,000 operations on the thyroid per year. And of course, I think it's clear that all these operations cannot be performed in specialized or in so-called specialized centers only. So you need an approach, a nationwide approach, which doesn't increase the number of complications in total. So the problem set by the endocrinologist, starting with that debate, they said, are you perhaps performing too much diagnostic thyroidectomies? Are you performing too extensive procedures for these patients? So perhaps at first, too much diagnostic thyroidectomies. What means diagnostic thyroidectomy? I think it's a very difficult term, but when I tried to analyze that, I compared the number of thyroidectomies due to benign goiter with that of malignant goiter. And the relationship was 1 to 15 in Germany, much more than in Italy, UK, and Scandinavia. Of course, the reason for that in Germany, perhaps 50 thyroidectomies for benign goiter are performed, but only one of that was for a malignant goiter. Maybe different reasons. Of course, these are the surroundings, the food iodine content, the health system, And of course, more and more, only the costs means health system, but also includes the ultrasound availability, the standards, the experience. Also for that, there is some experience needed. The non-thyroid related imaging and the specialization and the multidisciplinary teams, how experienced are these? Are there any guidelines from the national societies? But last but not least, also that includes the information from the general practitioners, the recommendations for operation or against operation, the information by specialists, by organizations, by the internet. Many patients are informing themselves by the internet directly. And of course, there is also a preference independent on science or independent on medical findings by the patient, by the family, or by the doctor. So the indication to surgery is a multi-factorial thing and not only coming from the medical findings itself. So the reason that in Germany perhaps there is some concern related to the cytopathology, the fine needle aspiration cytology, is not only that multinodular goiter means a sack of potatoes, so that is sometimes really difficult to select the nodule who is most suspicious, but it's also related to the success rate of cytology, and at that point it means that in benign goiter the meta review and the prospective clinical FNA study data are very, very closed, but also on the other hand there are also some differences. The post-op diagnosis of malignancy in the meta-review was 6%, and in the prospective clinical trial it was 11%. And these differed between the academic sites and the community sites. So from a point of view selecting patients for surgery or not, the benign cytology is perhaps not the ideal method. And that embedded in a thyroid with multiple nodules, I think this increases the unsafety for such a method when it is used only for selecting the patients. So the next point would be too extensive. Are the procedures related to the thyroid, and that means total thyroidectomy, is too extensive for most of the patients? So the historical perspective in that regard is very interesting, and this is the very famous sister pair which Theodor Kocher gave the Nobel Prize, because this is the difference in size of these both, the younger one, the elder one, and some years later, after total thyroidectomy, the younger one is that here, and the elder one stayed at that size and didn't grow. So this observation that was made by Theodor Kocher and then published immediately was followed by a decrease in total thyroidectomy. So this was the rate of total thyroidectomies till 1883, and then he published the results, the disastrous result of total thyroidectomy, because at that time they had no knowledge about that, and then he decreased immediately his personal rate of total thyroidectomy. So this historical thing, I think, is really very interesting. After that time, there was a discussion in the scientific community, and they tried to overcome the metabolic disaster of Kocher by thyroid transplantation. And this was published by Peyer, at first transplantation of thyroid tissue, and he took thyroid tissue from the mother and transplanted it to the child of that mother here, and 2 months after the thyroid transplantation, the child looks very, very good and improved compared to that situation before transplantation. So there are several attempts at that time, but at the end, of course, this was not really successful. So the second attempt was, and this was the name Mikulic. I think you all know this name, but also by others, who tried to preserve some thyroid tissue at the posterior part of the thyroid, because, as I will show later, because of course also at that time it was very well known that the posterior part was the most dangerous part of thyroidectomy. And they performed a subtotal thyroid resection by removing more the anterior part of the thyroid and leaving that posterior part of the thyroid for thyroid hormone production, but also for reducing the number of complications. And Enderlen Hotz from Switzerland, this is taken from the Sauerbruch textbook, and others then introduced the subtotal thyroidectomy as a standard procedure, and you can see here some remnant of the thyroid on both sides. And after that subtotal thyroidectomy, there have been introduced other types of thyroid preserving thyroidectomy, like the so-called Dunhill procedure. Riedel, who was the first surgeon describing the thyroiditis, was the first one who described hemithyroidectomy and contralateral subtotal resection, leaving the superior pole. Then Hartley described the procedure, and at the end Dunhill, which today is named Dunhill procedure. So the reality, what is the reality in performing total thyroidectomy in Germany? We did an analysis, and you can see here that the number was increasingly growing from 27 to 37%, but 37% perhaps is not 100% in multinodular goiter. This includes all thyroid procedures, so also the lobectomies are included in the scheme here. But that means that at present the percentage of total thyroidectomies in Germany is around 40%, not 80 or more. So our own department results are shown here, and you can see here that from 1995 to present, our institutional total thyroidectomy rate increased from about 20% here to now 80%. So 80% is the present rate of total thyroidectomies in my own department. So what are the variables influencing the extent of surgery in multinodular goiter? I would like to talk about in the next minutes. It is the recurrence rate, the expected recurrence rate according to the remnant size, and of course also the influence on post-operative TSH suppressant therapy. Do you have another pointer, perhaps? Because he's dying. The incidental thyroid cancer rate in resected specimen, the interesting observation on posterior nodules, and of course the main topic of surgical morbidity and surgical experience. So the recurrence rate of nodular goiter according to the extent of thyroidectomy of course depends on the type of procedure, if you have performed a partial or a subtotal or a total thyroidectomy, and there is a wide range. Thank you very much. There is a wide There is a wide range, as you can see here, and of course And of course, it summarizes the different extents also within the group of partial, subtotal and total. But of course it's clear that total thyroidectomy for most patients means that total thyroidectomy for most patients means that they will not develop any recurrence at all. So the recurrence rate, according to the postoperative TSH suppressant in that evidence-based review, was about 50% when the patients had TSH suppressant therapy, or about 50% when not. So that means that the TSH suppressive therapy is no way to be sure that post-surgical recurrence will not develop. And the incidental thyroid cancer rate is about 5 to 50%. So this, of course, is one of the arguments in favor of total thyroidectomy. About only 1/3 of patients after subtotal thyroidectomy needs to be completed due to invasive incidental thyroid cancer. So, can you give me again the pointer? So this may be an argument in favor of total thyroidectomy, but on the other hand, this is also a potential argument in favor of subtotal thyroidectomy, because only 1/3 of patients have to be a completion thyroidectomy. So the redo rate after primary surgery, and this is an institutional review, was also in total 5% for bilateral subtotal thyroidectomy and near 0 for total thyroidectomy. This is very close to that evidence-based review. So also this very recent investigation showed that about 5% of these procedures only needed to be completed. So what is with regard to the posterior thyroid nodules, you can see here that this dangerous area sometimes cannot be fully recognized when only the anterior part of the thyroid is removed. So the posterior part of the thyroid is perhaps not only the dangerous area, but it is also an area for recurrence, for the risk of recurrence, because in that area very often there are nodule formation that is not detected when you are not fully exposing the whole thyroid lobe. So this is shown here from the right side, the right thyroid lobe, and this was such an sucracundal adenoma located at the posterior part of the thyroid. And of course, the recurrent laryngeal nerve in most cases is behind such a nodule, not anterior to that, so that you have to remove the whole nodule, this sucracundal adenoma, before you can expose the nerve. So there are some special technical problems apart from the importance regarding the risk of recurrence. So whereas the recurrence rate, the incidental thyroid cancer rate, and the frequent posterior thyroid nodules are speaking more in favor of total thyroidectomy in multinodular goiter, which are the arguments based on the complication rates. And I will only show this slide here for perhaps more for discussion, and because at least myself and many of you are surgeons, we perhaps have not so many insights in the metabolic problems after thyroidectomy. But I think this was a very nice summarizing paper which appeared last year in Thyroid, showing that patients who have had a thyroidectomy have an increased risk of weight gain after thyroidectomy, which is similar like the hypothyroid patients, but these patients have been substituted completely by thyroid hormones and were not hypothyroid. So there is an inherent, or at least we do not know at the present time, a risk of patients gaining weight after thyroidectomy despite complete substitution therapy. And at least the patients in Germany are discussing very intensively about that. And because many patients are women in middle age, of course, there are also other risk factors for weight gain. And if that is an additional risk by thyroidectomy, by complete thyroidectomy, then of course this may be a point of concern. And this weight gain is also present 1 year after thyroidectomy. So it's not only a transient phenomenon after thyroidectomy, it is a net increase of weight. So perhaps sometime we will have embryonic stem cells but of course this is at present not the clinical practice. So the dangerous area of thyroidectomy, of course, is the posterior part, and at that posterior part you have everything which is dangerous. The recurrent nerve here shown, identified and verified by neuromonitoring, the inferior parathyroid, the superior parathyroid, and of course I think it's clear that the hyperparathyroidism is at risk when performing total thyroidectomy. But we all know as well that the recurrent laryngeal nerve function post-operatively is not routine in many departments, in many countries. And I'm sure that perhaps the recurrent laryngeal nerve palsy is much higher than expected. The calcium determination is very easy. So at present, the hyperparathyroidism is the most frequent complication after thyroidectomy, but perhaps it is only a consequence of measurement. If we would analyze all our patients, all, without exception, the symptomatic and the asymptomatic, after operation, regarding recurrent laryngeal nerve function, I think, or I am convinced that the complication rate regarding that item is higher than we are reading in the literature. So the recurrent laryngeal nerve pulse rate, of course, is a method of experience, but I would say that the term experience is really difficult. I would say, and this is shown in this slide here, that is not experience, it is the number. So there is a relationship between volume and outcome, and experience is defined as volume, not as eminence driven. It is defined with a clear number of operations which have to be performed to achieve a low number of recurrent laryngeal nerve pulses. And as you can see here, there is a difference regarding recurrent laryngeal nerve and hypopara. And this also is a strong argument that you can do many operations, but it is extremely difficult to reduce the hypopara rate. You can do many operations and then you will achieve a lower and lower recurrent laryngeal nerve pulse rate. But the same number of operations is not sufficient to achieve a very low hypopara rate. This is a calculation which has been performed based on the first multicentric study with more than 16,000 patients which are included in that study here. So the meta-analysis of that World Journal of Surgery volume in 2008 showed that subtotal thyroidectomy and total thyroidectomy, when compared, differ in regard to the transient and the permanent recurrent laryngeal nerve palsy and the hypopara rate, transient and permanent. But of course, also in these figures are differences regarding the extent and the experience, I would say, the volume of the surgeons. So again, the German multicentric prospective study, the PETS-1 study, showed differences according to the extent of surgery. And this was the subtotal thyroidectomy This is the Riedel-Hartley-Dunhill procedure and the total thyroidectomy, which have been compared here. And you can see a shift, an increasing shift to the right when comparing these complications apart from hemorrhage and these other non-recurrent laryngeal nerve and hypoparoleated complications. So I tried to calculate if you compare a scenario with initial total thyroidectomy, what is the complication rate based on a total thyroidectomy with a 2.3% total complication rate regarding recurrent laryngeal nerve and a 0 recurrence rate. So the pulses per 1,000 operations, the number of pulses is 23. When compared to the second scenario with initial subtotal thyroidectomy and a low recurrence rate, subtotal thyroidectomy 0.8% recurrent laryngeal nerve palsy rate and 5% recurrence rate, and of course this must be added 3.6% recurrent laryngeal nerve palsy rate for completion thyroidectomy, you will have in total 9.8 recurrent laryngeal nerve pulses per 1,000 operations. And scenario 3 is only to approach to that first scenario, and that means subtotal thyroidectomy with 0.8% recurrent laryngeal nerve palsy rate, and then you must have a recurrence rate of 42%, approaching to that primary scenario. But 42% is non-realistic. So that means when you are calculating that on the basis of a national scope, then you can say, of course, subtotal thyroidectomy with regard to the recurrent laryngeal nerve complication is the better procedure than the total thyroidectomy. We are talking about surgeons in total in a given national scenario. So the other arguments from the endocrinologists, but also from the patients, was that, and I can say from my own experience, we have published that in the Head and Neck 2012 regarding the first 75%, now it's 83%. From my own experience to review my practice claims, that you have a complete different type of complication complications than in that publications reporting about publications. So in that analysis we had 48, and this is perhaps half, 58% of patients who had a recurrent laryngeal nerve palsy, and 40% of them were bilateral. So bilateral recurrent laryngeal nerve palsy is a black box in scientific publications, but in reality it is quite frequent. And the same was with hypoparathyroidism. 17% of these patients had a trach, hemorrhage, mortality, you see here, hypoxic brain damage, including that in that group here. So this is a realistic picture, at least based on these malpractice claims. So what is the impact of new developments in thyroid surgery? Perhaps not to be too negativistic for the endocrinologists, seeing that also the surgeons are improving in some regard at least. I show here the results of the PETS-1 and PETS-2 study. These are the multicentric study with more than 16,000 patients included in the year 2000. And now we performed a comparing study with these numbers of patients. And you can see here that surgery with intraoperative neuromonitoring was about 60% in that group, of departments participating at the study. Now it is 90%. The permanent recurrent longitudinal nerve pulse rate per nerves at risk was 1.3 in that study, now is 0.7. And I would argue and speculate that this is the consequence, at least in part, of the use of intraoperative neuromonitoring. And another item was also very interesting, the rate of permanent recurrent longitudinal nerve pulses in relation to the rate of post-operative recurrent longitudinal nerve pulses, so permanent to post-op. In that first study, it was 33%, so that means 33% of patients who had a post-op palsy also at the end had a permanent. But this relationship was now 18% only. So that means the severeness of recurrent longitudinal nerve palsy decreased during that 10-year time period. And the bilateral recurrent longitudinal nerve palsy rate was 0.043 in the first period, and 10 years later it is much less, 10% less. So, and these are all surgeries. So also the number of recurrent longitudinal nerve pulses on both sides decreased significantly. And in part, at least, this is the consequence of a concept that is termed staged surgery, or changing concept when you have a recurrent longitudinal nerve palsy based on neuromonitoring at the first site when a bilateral procedure is planned. So we asked, and this was published just recently in the BJS, we asked the surgeons, are you performing contralateral surgery when you have a palsy at the first site defined by a loss of signal during neuromonitoring? And only 6.4% of surgeons said yes. The majority, the overwhelming majority, 93% of surgeons said we intend to change the strategy regarding the other side, either by reduction the extent of resection or not performing contralateral surgery at all. So that means that perhaps also that type of changing strategy in combination with intraoperative loss of signal by using neuromonitoring when it happens on the first site can change the risk of morbidity related to the recurrent longitudinal nerve palsy. And that means, of course, at least when not performing nothing on the other side, do a subtotal resection on the other side. So the continuous vagus stimulation, which is the last experience and last generation of intraoperative neuromonitoring, perhaps can resolve that problem because, and you see here the latency online registration, and this is the amplitude registration. You can see here when the amplitude is significantly going down, then you have a warning situation. You can leave the thyroid immediately. This is what we are doing. And to stop doing anything, wait for some seconds or at least till the amplitude is again increasing. So this continuous neuromonitoring seems to be a very effective method to be warned, which is not possible with the technique of intermittent. With the intermittent neuromonitoring, you always have the information after something happened. So these are new developments in thyroid surgery. And when comparing the intermittent and the continuous neuromonitoring, you can see here that also the continuous neuromonitoring is better regarding the false positive rates and the false negative rates. False positive, loss of signal but post-op intact vocal cord. False negative, intact vagus nerve but post-op vocal cord paralysis. And this was 0 false positive but still present in the false negatives. So there is some improvement what we have to discuss about. but at least regarding the false positives, there is a significant improvement by continuous neuromonitoring. And at the end of that period, in our department, we had 0 vocal cord paralysis 6 months after operation, with a continuous 0.5 with the intermittent neuromonitoring. So this warning effect perhaps may be achieved or may lead to a true 0 or at least near 0 complication rate regarding the recurrent laryngeal nerve. So the benefits and risks of total versus subtotal thyroidectomy are summarized in this slide. I think coming from the discussion before, you all know the benefits and the risks. The benefits of total thyroidectomy are that there is no recurrence, at least for the majority of patients, if you did not leave any thyroid. And there is no complication thyroidectomy for incidental thyroid cancer. These are the 2 important benefits of total thyroidectomy, whereas subtotal thyroidectomy, there is some preservation of some endogenous hormone production and regulation. And regarding the weight gain of total thyroidectomies in women, I think you can see that this may be an important argument in favor of subtotal. There are less complications. I think this is there is good evidence for that, and the risk on the other side are reflecting the contrary. So summarizing these and putting that in a concept, there may be some individual indications for subtotal thyroidectomy that are for patients who have these preoperative or intraoperative risk factors or no risk factors, better to say. Subtotal thyroidectomy, low risk of recurrence, the asymptomatic patient, the patient who has already a pre-existing recurrent laryngeal nerve palsy, a reduced physical state, and personal risk factors, that means speech profession, metabolic impairment, and the unavailability of thyroxine, and that also may be for some countries an argument. And of course, there are also some intraoperative arguments in favor of subtotal thyroidectomy. So, my personal view on that debate is that, and as I have shown in the first slide, that of course total thyroidectomy should be the procedure of choice for most patients, but I think there are also some arguments to leaving some thyroid tissue in special patients. Thank you very much for your attention. Teşekkür.